Welcome, everyone. Just in the interest in time, we'll get started. Some people will probably continue to trickle in. Wanted to thank everybody for joining and just let everybody know if you have colleagues or anyone who wants to watch it, we're going to start recording these and making them available after the fact. Today, we're going to take a look at the recent Lancet article that describes outcomes in patients with COVID undergoing ECMO. It's a timely article. I think it's of interest to everybody, especially coming out of the last several months. And I'd like to just highlight that we've been fortunate enough to have first author, Dr. Ryan Barbero, join us from the University of Michigan, and senior author Dan Brody join us from Columbia University. We've been fortunate enough to get study authors to participate in these journal clubs, and I think it really adds to the richness of the discussion afterwards. I'm also looking forward to some of the perspective that we get from other regions around the world. So I'd just like to thank you both for coming. And then I'd also like to introduce Dr. Nicholas Gobel. He's a cardiology fellow from McGill. He's in his second year, and he's planning on pursuing training in critical care medicine. He's kindly offered to provide us with a 10-minute overview of the article, and then we'll follow with 15 to 20 minutes of discussion and wrap up from there. So I'll let you take over the screen share, Nicholas.
Perfect. Oh, you have to stop your screen share first.
Okay.
All right. It should be working now. Everyone sees the presentation?
Yeah.
All right, great. So without further ado, we'll start with a presentation of the paper. Hopefully I do justice to the authors today. All right, let's go. So the clinical questions was using the ELSO registry, looking at patients to hopefully characterize the epidemiology and the hospital course and the outcomes, especially in patients 16 years older, old and older, with a confirmed diagnosis of COVID-19 diagnosis who required ECMO support. As we know, ECMO is being increasing worldwide for management of those acute ARDS, and ECMO is often the last resort for ARDS with refractory hypoxemia. Several international institutions and organizations recommended the use of ECMO in expert centers for refractory ARDS. Those organizations such as the WHO, the Surviving Sepsis Campaign, and the ELSO organization as well. And we all know in the past year, COVID-19 has been associated with some severe cases of ARDS. We had some early reports from China and other countries that COVID-19 patients who required ECMO had a high rate of mortality. So the study was to address this issue. So it was an international cohort study using the ELSO registry between January 16 and May 1st, but data were updating until August 3rd of 2020. Population, as I told, was patients who were diagnosed with COVID-19 as of a confirmed laboratory testing of a COVID-19 infection with presenting acute respiratory distress syndrome. They had to be 16 years and older and had to go under ECMO support. Then there were subset analysis of patients depending on if they had classified by ELSO having ARDS, patients who do not meet the criteria of ARDS, and the subtype of ECMO, either VV or VA ECMO. As we see the population, we started the eligible population with 1,093 patients in the registry. 57 were excluded because they did not complete the COVID addendum questionnaire and confirm the COVID-19 status. One patient had a previous ECMO run, so he was excluded. So we have 1,035 patients for full cohort analysis. And on the right, you see the breakdown for the specified ARDS cohort. So median age of around 50%, around 75% male, of predominant white as a third of patients. So some of the pre-ECMO comorbidities, around a third of patients didn't have any comorbidities, a quarter were diabetes, and about half of the patients were obese. So let's us with the 819 patients in ERDS in the total ECMO group, and in the subtype of ERDS, 100%. There were 22 myocarditis patients. 60% had no co-infections as well, and 12% with around 12% of bloodstream infections. If we look for pre-ECMO therapies, most of the patients will have non-invasive ventilation, around 60% before intubation, and before ECMO, they were intubated for around 4 days. And they received conventional ventilation almost 100%. They were on FiO2 of 100%, and their PF ratio in the 70s, so severe ARDS. Received PPAP in around the 15. So pre-ECMO support, most of the patients had prone, neuromuscular blockade, and around 60% had a vasoactive support. If we look at specifically COVID-19 therapies and or immunomodulators, 40% were on steroids, and around half of them were on chloroquine or hydroxychloroquine. So around 700 patients received care in another hospital before they were transferred to an ECMO center. Around 330% had ECMO initiated outside that hospital before the transfer. So like I told you, around 40% on steroids, 50% on chloroquine or hydroxychloroquine. 96% had VV ECMO, had a total of 9 patients receiving VA ECMO and 4 patients with other type of ECMO support. So if we look down to outcomes, the primary outcome was in hospital death in a time to event analysis at 90 days after the ECMO initiation. And they used the time to event analysis, and the authors can comment on that afterwards, in order to assess for patients who did not have a final disposition at the time of analysis. Like I told at the beginning, they were still updating the data as the paper was as of August. Other secondary outcomes were the patients remaining in the ICU, discharged from the ICU but still in a hospital, discharged home or a rehab, discharged to a long-term care facility, or discharged to another hospital or had an unspecified location. Other data as they collected all here. The statistical analysis, I won't talk too much about it, was the use of Eglen-Johnson estimation of cumulative incidence of in hospital mortality measured at 90 days, and the estimation of the cumulative incidence rather than the proportion, because not all of the patients achieved the event at time of analysis. So the results, the median duration of ECMO was around 14 days. 44% of patients received renal replacement therapy. 55% of patients had one of the pre-specified ECMO complications, so a bit more than half, and it was mechanical failure of the circuit for 28% of the patients, and you have the breakdown on the right of other complications as well. Time of analysis, 968 patients of the 1,035 had a known status, so around, so 94% of total analyzed patients. 588 were discharged from the hospital, so 57%, and of that, 30% went home or to a rehab center, 10 to a long-term care facility, and 17% went to another hospital, and most of the time was the referring hospital. 380 patients, around 39% of the patients died. And of those 380, 309 died within 24 hours of ECMO discontinuation. And in a proportion of 85% of those patients had a very poor prognostic, and that's why the ECMO was stopped. Here's the Kaplan-Meier curves of all of the known locations at 90 days of patient analyzed. And I think we can see the patient that died. And on top, on the orange, the patient were discharged either home or rehab. So the result was that was an estimated cumulative incidence of in-hospital mortality at 90 days was of 37.4%. And if we look into the subgroup of VV ECMO with ARDS patients, the estimated cumulative incidence of mortality at 90 days was 38%. And if we look in terms of duration of stay, was around 26.9 days. And if we look between the survivors and the non-survivors, it was twice the number of days, the median of 31.1 days for survivors and the 16 days for non-survivors. And if we look at patients who are still in the hospital at 40 days, the estimated in-hospital mortality at 90 days was 14.1%, so way less. Here's the graph of the cumulative incidence of mortality over the 90 days period. So VA ECMO was significantly associated with an increased mortality of 1.89 hazard ratio. Age as well was increased with an increase in age was also associated with an increase in mortality. The group of 70s and above had 3 times the outcome as the group of 16 to 39. And you see other factors that were associated with increased mortality, such as having cardiac arrest, having AKI, chronic respiratory problems, or being immunocompromised. Here's a breakdown of other subgroup analysis who had other risk factors for hazard ratio for the primary outcome. So that's about it for me for the breakdown of the study. We'll now let Dr. Fagan and the authors comment on the study and the question period. Thank you, everyone.
Thank you for presenting that. I really appreciate it, and it sort of sparks the discussion. I know that the study for us was informative and just providing some encouragement on putting people back on VV ECMO during COVID. I'll open it up to the floor if anybody has any questions. Then if not, I have a few questions and comments. So maybe I'll get the discussion started then. So at our center, which would probably be a medium-sized center in Canada, probably small compared to American standards for mechanical support. One of the things that I sort of observed and was maybe a little bit different from your study is the patients that we put on ECMO were almost more of a rescue therapy. They were prone and they had neuromuscular blockade. And also, again, this is just an observation on a limited number of the cases I was involved in. Their lungs seemed to become entirely fibrotic with no chance of ever getting off ECMO, it seemed, even after several weeks. And that's quite a contrast to the study population that we see, where there's less neuromuscular blockade at about 70% and less proning. I just wonder if you could comment on the difference in population and maybe your own thoughts on the ideal sort of timing of ECMO in COVID.
Ryan, do you want to take
it? Yeah, I was going to say, Dan, please take this first.
Sure. First of all, Nicholas, that was a terrific job. That's exactly how we presented. So yeah, whether that's good or not, you definitely did it like we did. So yeah, I think you did a great job. Andrew, these are really tough questions. You sort of started with the toughest. Let me give you a few related thoughts. One is, this is an international experience, 36 countries, 213 centers. And the fact that we had 60%, it's observational data, this is not a prospective study, but the fact that 60% of patients were prone prior to being put on ECMO, with the vast majority being ARDS, I find astounding in a good sense. You know, previous trials had abysmal, particularly in the United States, where prior to COVID, it was rare to find anybody who would be prone. You know, it was a really small percentage of patients. And when you look at the lung safe data published in JAMA a few years ago, you know, which is across almost 500 ICUs around the world, the rate of prone positioning for PDEF less than 100 was, you know, 16.2%. And so the fact, I agree with you, it should have been 100 or virtually 100, you know, only in those who weren't contraindicated, but I still was very impressed that 60% of these patients were being prone. Now, I think this experience over the last year has forced much of the world to learn how to become more comfortable with prone positioning because we've seen so much severe ARDS. So I agree with you that it should have been higher, but I'd like to, in the context of what we've seen previously, I actually thought it was quite a bit higher than what we would have anticipated. That said, I think and the rate of neuromuscular blockade, you know, I think sort of goes along with that. Maybe it speaks to a population that might not be as sick as what you're seeing. But part of what we're observing now is that this population is the beginning of the pandemic from January until May 1st. And we have noted that, at least observationally, looking at the data for ELSO, we now have, you know, well over 4,000 cases, that the mortality has been creeping up throughout the year. And that we are seeing different patients now. And when I say now, we're going to look at the data pretty soon, actually, and Ryan's pulling that now, at least just to get a sense of what's happened since this paper. But clearly, over time, there's been an increase in mortality, and clearly there's some difference in the patients that we're treating. So as much as your conclusion from this paper is correct, your puzzlement at, you know, how this could be, based on the patients you're seeing, is also correct. You know, I think this conclusion may actually be more relevant to a population that we may not be seeing anymore. And so why would that be? Well, only hypotheses. So take everything I now say with a grain of salt. But some of the hypotheses are that we're now selecting for sicker patients. You know, and you saw 40% or 41% received corticosteroids. You know, now it would be virtually everybody who's this sick. And so perhaps some of those patients, if they had been treated with steroids, never would have qualified for ECMO. And so now we're selecting for a more severe population. And that actually might be the case in a few ways. Another hypothesis that's very prevalent as a hypothesis within the pulmonary community is that we've all started, you know, sort of collectively started using more high flow nasal cannula and non-invasive ventilation prior to intubation and for longer periods of time. And in doing so, we may have a lot more patient self-inflicted lung injury. So that by the time we get them on ECMO, and the purpose of ECMO in the vast majority of patients is not to oxygenate, that's a small number of patients. The purpose is to be able to do ultra lung protective ventilation in patients, particularly those who have very stiff lungs. If they come to us and they've already beaten their lungs up entirely with, you know, a lot of lung injury that has worsened prior to even being intubated, prior to being on ECMO, then it may be that they can't benefit as much and the mortality would be higher. So there could be viral variant differences. There may be differences in the size of the inoculum that, you know, change the course. You know, so early on when no one was wearing masks and social distancing, the inoculum size might have been huge. These patients might have been very inflammatory, gotten very sick, and ended up on ECMO when they were actually going to then turn around pretty quickly. Again, hypothesis. Whereas now with social distancing and masks, you might see much less of that, much less of the multi-hit hypothesis of inoculum. So I think we are seeing different patients. I don't think we know any of those things to be true. I think those all remain, you know, possibilities. When we look at the data, all we're going to be able to say is observationally, yes or no, it does look like things are getting worse. But your observation is also our observation at our center and many centers that I've spoken with, where we see that the outcomes have not been as good since the spring as they were in the spring. And for us in New York, spring was not a time where we had the luxury of doing anything the way we would normally do it. It was, you know, bedlam, and yet we had better outcomes. And so I think that does speak to something different that's going on. I don't know, Ryan, if you have other thoughts about that.
I mean, I think without rehashing what you said and saying that, you know, I agree, and certainly in terms of like the, you know, your comment, right? Like, or sorry, what we presented, that 40% of patients were receiving a proven therapy that didn't work in hydroxychloroquine, you know, like, and then now, you know, that most patients are receiving a therapy. Like I was just looking at the website because all of these tables are kind of recreated in real time. Just if you go onto the ELSO website, what the current, like some of these things are. And so the prone positioning, unfortunately, is no different. It's lower. I'd have thought that this would come up over time, but the use of steroids continues to climb, and as like Dan said, is much higher now. But I think that the other that I would say is, in addition to kind of that we may be causing harm, like you said, Dan, in terms of just the non-invasive ventilation, and we see also that the days of mechanical ventilation have reduced by a full day, which again I think speaks to this idea that we're probably doing something a little bit different with these patients prior to getting on ECMO, and normally we would think that that would be protective, right? And so maybe we are causing harm with the non-invasive ventilation that we're doing prior to transitioning, and that certainly it seems like is echoed. The only third thing that I would say, and I think this is I don't think this is something that's going to be clear from the data that we've collected, but we may be able to look at and hint at, is that we also may be selecting different patients. I certainly remember, as a community, right, when we first started talking about selecting patients, it was really worried about like who's the right patient because we are constrained in resources, and that has certainly ebbed away. And so I think those would be the three things that I would hypothesize as well.
Yeah, it's interesting. We kind of, again, it's all anecdotally, and I, as a fellow in critical care, I'm only on the service a little bit of time, but I noticed that a little bit too. We've moved to much more sort of high flow and avoiding intubation, and you wonder if that does change the patient population quite a bit. We do have a question coming in here from the audience via typing. Let me just read it out. Someone commented if either of the authors would be willing to comment on the systems level aspects related to protocolizing time to early EV ECMO or any MCS for that matter, now that we're sort of shifting to more hub and spoke models of care. Should there be sort of protocols in place so that you're getting the standard same patient on all the time, and how do you sort of facilitate that type of care? I don't know if that.
Ryan, you want to?
Or a systems level approach to early lung protective ventilation.
I mean, I think it's a great question. I think, Dan, I assume you would say the same as, if we were going to systematize where you would start to evaluate a patient to come on ECMO or talk about transitioning, I think the initial anchor is going to be, the threshold at which patients were brought onto ECMO support in the EOLIA trial. And so since if they're coming from a spoke to your hub, obviously you need some wiggle room to be able to safely transport those patients if you're not cannulating them at the outside at that kind of point. And so, you back it up a little bit. I guess what I would say in terms of, when we think about those things, and these aren't collected in the same way at all, but when you look at the PF ratios and things like that, that you would expect to kind of anticipate those things, as well as the ventilator settings that you would expect to anticipate those things. The pre-ECMO mechanical ventilation strategies and measures of hypoxemia that we record in the ELSO registry don't seem to be the things that are driving these differences, which isn't to discount the import of what you're talking about. It's just that I think, in the setting of COVID-19, it seems to be more complex than that, and it may not just be that's going to arrive us at better outcomes.
Yeah, I think that's a great answer, because the question could be taken at face value in general, or you could be speaking about COVID. And if you're speaking about it in general, there's no question that it is better to have an organized system within a region where hospitals that are capable of doing ECMO, or at least capable of maintaining patients on ECMO for a period of time, are set up in a hub and spoke model, as Ryan said, and as the question implied. And I think the more you can standardize that, and probably the best example I've seen of this, I mean, the UK is very standardized. They have, 5 official ECMO centers in the UK that are commissioned. You can do ECMO at other hospitals, but you won't get reimbursed. And they have real standardization of their criteria for going on ECMO, for all of their policies related to ECMO, and they have a good referral system. But the country of Qatar has a really organized system. Now they have one major medical center, Hamad Medical Center, which is fantastic tertiary center, quaternary center, but they've really partnered with all the hospitals in the country to create standards for the approach to lung failure, the indications for referral and then the indications for ECMO, and they have a great transport service. So that's sort of, you know, they have a lot of advantages in being a small country with one referral center and a lot of control over what goes on at the other hospitals, but still that would be the model. I like the way Ryan started that, because he started it with, well, who would you put on ECMO? And, you know, and I agree, you know, the most logical approach currently would be to use the EOLIA criteria. If we then transition to talking about patients with COVID, I don't know who those patients are. And I don't know how well the EOLIA criteria apply in these patients. And as much as what I totally agree with what Ryan said about patients at the beginning, you know, many centers were highly selecting patients. Truthfully, we're more highly selective now than we were then, and we're not having as good outcomes. So, you know, I'm not sure that just going by EOLIA criteria tells me who I should and should not put on ECMO right now. And we're struggling with deciding who's going to do well. And the one thing I can tell you is that so far, everybody in their 20s has done well, but everybody in their 20s has a lot of reserve. So, you know, that just tells you that young people are hard to kill. So I think, you know, it's a very difficult question to say, how do you set up a system like that? I'm not sure that we know enough currently based on the data to even know what the exact indications are in COVID. And I would call that a moving target based on what we had just discussed.
Okay, thanks. I'm still getting some questions coming through in the via chat to me. If anyone wants to speak out loud, that's okay too, but I'll read some of these questions off. There's a technical sort of data capturing question. Someone had asked, wondered if the ELSO database captures any information on cannulation strategies. There was a recent ELSO ECMO course, then there was a lot of anecdotal discussion about using the Protect and VV ECMO to offload the RV in severe ARDS, and that may improve survival, and any nuances of other cannulation types, Avalon, FemFem, FemIJ, those sorts of things.
So I think just acknowledging that I wasn't there, what I'll say is, so it sounds like we're comparing bicable cannulas generally, like the Avalon and the MC3 Crescent being two bicable cannulas, to the Protect Duo, which is a cannula that's intended to go, you know, through the RV into the pulmonary artery. And so just clarifying that. And so the Protect Duo is not always used in that way. And so like, I would just say we do collect all the manufacturer information in terms of who's doing it, whose cannula is being used. And so you could analyze the data from that perspective. Also tries not to release that data because we don't want people to get into the situation where they're like incompletely using information to compare manufacturers and maybe like, you know, giving some misinformation there. What we do, and I actually think is the better way to ask this question, is we have a new mode. So I think we've always had these modes of VV and VA, VVA, which has gone by different names over time. But now we have a mode called VP ECMO. And what that refers to is exactly the question that's being asked, which is, you know, what do you call this thing when it's all on the venous, or sorry, on the right side of the heart, but it's not VV ECMO. It's making into the pulmonary artery. And so we name this thing that is offloading exactly as it was stated, the RV. Somebody should ask that question. They should submit a data request to ELSO Registry to compare VP with you know, other analogous situations.
There you go. The commenter who asked that question, there's something for you to consider for a next project.
Yeah, I mean, also the controversy that I think the questioner was raising is around the paper out of Chicago. Is that correct? I don't know who asked the question, but that's where the data, you know, that's sort of where the data came from that raised the issue about whether or not using Protect Duo in the setting of COVID ECMO was beneficial. So I don't know if that was the discussion that went on at the course, or maybe I was part of that discussion. I don't remember.
And I see something about a Rush University paper.
Yeah, exactly. So that was Asif Mustafa and Akash Joshi and their colleagues. They're at Rush and Adventist Christ, and they basically at the beginning of the pandemic just made a decision that they were, after their first patient, they decided to use Protect Duo. And so they've used Protect Duo, and they reported this in a letter to JAMA Surgery with their first 40 patients. And they reported 85% survival. In a follow-up letter, it's 82.5%. Not going to quibble, amazing results. And so your first reaction when you see something like that should be, okay, well, maybe they weren't such sick patients. Well, then you look at the data, they're pretty sick patients, and they're actually quite similar to the patients that Nicholas just presented to us, with relatively similar characteristics all the way across the board. It's not entirely the same, but not so different that you would expect such a difference in mortality. And what's interesting is, despite what I've said about a lot of centers struggling struggling in more recent months with outcomes, they have not been. They have actually pretty consistent results, and they've done over 100 patients like that. What I would warn against, though, is just to think of that their data as an argument for Protect Duo, because they did a whole variety of things, and I would consider this a package of interventions that came along together. First of all, well ahead of the recovery trial, back in March, they started using steroids at high doses, higher than recovery, and they've continued to use that protocol. They used inhaled nitric oxide in every patient. They used direct thrombin inhibitors at relatively higher doses than they would normally use. They did a few things. They attempted to wake the patients up and get them out of bed. And one of the things people mistake is, oh, we can just wake everybody up. No, it was a median of day 13 in the original letter. I think the later letter, the follow-up was maybe a little bit before that. So it took them a while to get people awake, but these patients are on for quite some time. So they got them awake, and many of them they got walking around the ICU. So somewhere in that package of interventions, they did something really well. I mean, there's no denying it. Maybe their patients are a little different, maybe they're a little less sick, but there's just that difference in mortality is striking. So part of the hypothesis could be the Protect Duo. There's no question, especially if we believe that there are more PEs in this patient. Imagine your patient on VA ECMO or VV ECMO, and all of a sudden they have a PE. Well, if you're bypassing the right ventricle, you're at least going to be able to provide an RVAD to support the patient who's got a PE. Unless it's so massive that you've cut off the circulation. So it's possible it's actually quite possible that plays a role. What role it plays, we don't know. And so trying to get them to compare their data to some other centers to begin to understand, so we can tease apart the differences that might account for this, and then do, ideally, it's very hard these days, but to do a small, a quick series of pilot RCTs to try to figure out which element of it is contributing the most to the benefit their patients are seeing. But it's very interesting.
Great, thank you. I'll try to keep us on time here, but there was one more question that came through. So there was just a question about the decision to do ECMO before transport to a center, or to transport to the center, then do ECMO. I don't know if that's probably very center and region specific, but if either of you had any comment on that, that was one of the questions asked as well.
If I could just walk back to the previous response as well, I just think that's another reason why it's valuable to ask these questions out of multi-site registries such as, ELSO is, right? Like, I agree with Dan entirely that there is so much in the center impact of care, even well beyond the things that are reported. But then just moving on from there, yes, the way that whether you make a decision to cannulate a patient at the outside or the inside, obviously is very multifactorial and center specific, but I mean, including the availability of resources, the availability of, what kind of transport you're going to take and how long it's going to take to get a patient back and forth. And also, what you think your safety of moving that patient is with or without. And so I don't think this is a one size fits all, but I definitely think that, both at Michigan and at Columbia, we have transport systems that work well. I will say that we certainly modify, at least for our group, what kind of cannulation strategies we take at outside institutions versus within our own. So we do avoid like 5-cable cannulations at outside institutions and things like that. That's all.
Okay. Another question popped through here. So relating to putting patients on VV ECMO before intubation or proning, is this something that's going on in the States or elsewhere? I think that would be uncommon in Canada from anyone I've spoken to, but I don't know if anyone has experience with that there. Yeah,
there are 2 centers that I'm aware of that have been doing that. Personally, this is editorializing, but personally I would consider that to be research. and if done with a research protocol, I think, you know, with a good hypothesis as to why that would improve outcomes, I think that's totally reasonable. It would be nice to have some preliminary data going into it. I don't think I would recommend that. I don't think the data support that. It may be the best thing for the patient. You know, again, that when you do research, you start with a hypothesis. You can be right, you can be wrong. And when it comes to something where we really don't have an answer, I think we're probably better off trying to gather more data. So my hope is, at least for the centers that are doing it, that they're gathering observational data to share with the community so that we can begin to form those hypotheses. But I wouldn't recommend that at this time.
Yeah, well, and even sharing from their systems level how you operationalize that. I know from the limited 2 centers that I've trained at, you couldn't put somebody awake on ECMO and actually mobilize them and stuff like that. It's sort of smaller centers. It'll be interesting even how they get that working in their centers. And I imagine just having a high volume and slowly working your way there is part of it. But
yeah, I mean, we do awake cannulations for some of the bridge to transplant patients. So, you know, we have some experience with that, but obviously for a totally different purpose and in a very different population. So yeah, I agree though, it's technically trickier, not for the faint of heart. ECMO is not for the faint of heart, but you know, it is definitely tougher, and I think you have to have a lot of experience. The center that I know that's doing this somewhat routinely is very experienced. So, you know, that, you know, I think for them, they're able to do that pretty well.
okay. I'm gonna end shortly just to keep everybody on track, but I'm gonna selfishly ask one more question that I had. I may have missed it in the article. Is there a median duration of ECMO for survivors? One of the questions that came up for myself and others here was just, when do you stop and when might you expect lung recovery in some of those patients? And I know the median duration for everybody was about 2 weeks, but I'm wondering if survivors, if you're expecting, you know, 3-4 weeks before you start to see some pulmonary recovery. And I didn't know if you had any comment on that from the database or from experience.
From just the data, what I'll say is that they're not as different as I would have expected. I actually, you know, when the data first streamed into ELSO, you know, mostly what we got first was the people who die, right? Like, because they reach a disposition faster. And so I really thought that the duration of ECMO support would be really substantively different between those who live and die. It's just that they reach a disposition generally faster. It's not necessarily that their ECMO runs are much, much shorter at an ELSO registry level. You know, I think that that somewhat resonates with me, is that, you know, like, we certainly get a spread of patients clinically, right, that go on to live and go on to die, both when the runs get longer. Obviously, you know, the longer the run gets, the more that I think we start to all become a little bit impatient and concerned about what's going on. And certainly in the strain of COVID-19, when you're maximizing your resources and you're becoming more and more concerned, it certainly could put you some difficult ethical questions. But what I can say is just that from a data perspective, we don't see substantial differences between those. The length of time is a little bit shorter, like a half a day shorter, is what I remember. But you're right, it's not reported in the article.
Okay. But I would actually love to keep continuing to pick your brain on some of the practicalities of it, but I think I should keep things mildly on schedule. If anybody else has any questions, speak now. If not, we'll end here. I really appreciate you guys coming in. The article is hugely impactful, right? Just having that data to guide, because I'd imagine there, as in here, a lot of people had questions about, should we be putting patients on ECMO, and from a resource utilization point of view. And it's extremely helpful to have a yardstick to measure and say, okay, this is a reasonable thing to do, and who we're putting on is sort of similar to the rest of the world, and they're having okay success. So I thank you for your article, because it did have impact here on our clinical practice, and timely as well with the second wave.
Well, thanks so much for inviting us. We really appreciate it.
Thank you. Take care, everyone.
All right, be well.